Hi, class. As we discussed last week, adequate functioning of the kidneys is essential for an individual's health and well-being. Patients with compromised renal function or urinary alterations may present with a variety of clinical manifestations, and it will be essential for you as the nurse to be able to identify the signs and symptoms early and prioritize appropriate care. So, our learning goals for this session include understanding the signs and symptoms of upper and lower urinary tract infections. This will help drive care and decrease the chance of life threatening complications. Understanding the cause and proper care for individuals with urinary incontinence will allow you, as the nurse, to provide patient centered care. And learning how to apply the nursing framework with patients with renal calculi and other urinary alterations will support you in your practice skills in the clinical setting. So here's a video that explores urinary formation as well as elimination, and this will help to give you a firm foundation and understanding so that you can understand some of the alterations. A lower UTI is usually caused by bacteria entering the urinary tract through the urethra. Other sites of infection include the bladder, prostate. Often E. coli is the most common bacteria. Bacteria enter the urinary tract in three ways: by the transurethral route, this is ascending infection, through the bloodstream, which is widespread, or by means of a fistula from the intestines, which is direct extension. The most common route of infection is transurethral, in which the bacteria, often from fecal contamination, colonize the periurethral area and then enter the bladder by means of the urethra. So when we look at the figure on your slide, in A and B, this shows the urethral vesicular reflux. This happens with coughing and straining, and bladder pressure rises, which may force urine from the bladder into the urethra. So when bladder pressure returns to normal, the urine flows back to the bladder, which introduces bacteria from the urethra to the bladder. With the ureter uvesical reflux, this is the failure of the ureterovesical valve when urine moves up the ureters during voiding and flows into the bladder when voiding stops. This prevents complete emptying of the bladder, and it also leads to urinary stasis and contamination of the ureters with bacteria-laden urine. So the uropathogenic bacteria refers to bacteria or pathogens that are most commonly disruptive in the urinary tract system. E. coli, as we discussed, is the most common. Women's shorter urethra puts them at greatest risk for bacteria. These are some other risk factors. Women are more likely to get UTIs than men because their urethras are shorter and closer to the rectum. Pregnancy can cause pressure on the bladder, incomplete bladder emptying, and damage to the renal system. Sexual activity may introduce bacteria and microorganisms. Structural problems in the urinary tract area, such as enlarged prostate or kidney stones, can trap urine in the bladder and increase the risk of UTI. Wiping back to front can introduce bacteria and microorganisms. Diseases like diabetes and HIV can weaken the immune system, which can increase the risk of UTI. Catheter use can introduce bacteria and microorganisms to the urethra and bladder. And finally, urinary surgery or urinary tract exams that involve medical instruments can also cause the risk of UTI. So the answer for this one is 1, 3, and 5. Most common age groups for UTIs are women from 18 to 30. Pregnancy is also a risk factor, and sexual activity. So, if you have a history of renal calculi, that also puts you at a risk for developing a UTI. UTIs result in signs and symptoms that are very similar to other infections, including fever and tachycardia. However, a UTI will also include urinary alterations like incontinence, urinary frequency, and hematuria. Some patients are initially asymptomatic until the infection travels and becomes more systematic. Older adults may initially present with confusion. A urinalysis is necessary for diagnosis. The urine may show the presence of nitrites, and leukocytes. White blood cell count may also be elevated. If there are other complications or the infection is suspected to have traveled to the kidneys, imaging may be necessary. UTI is the most common infection of older adults and increases in prevalence with age. UTIs occur more frequently in women than in men at younger ages, but the gap between the sexes narrows in later life, which is due to reduced penile vaginal intercourse in women and a higher incidence of bladder outlet obstruction secondary to benign prostatic hyperplasia in men. In older adults, structural abnormalities secondary to decreased bladder tone, secondary also to stroke or autonomic neuropathy or diabetes may prevent complete bladder emptying and increases the risk of UTI. The absence of estrogen in postmenopausal women also make them susceptible to the colonization and increased adherence of bacteria to the vaginal and urethral walls. The antibacterial activity of prostate secretions that protect men from bacterial colonization of the urethra and bladder also decreases with age in men. Major goals for the patient may include decreasing temperature with acetaminophen and monitoring for signs of complications, administering antibiotics on time and as per frequency for the provider request, using analgesics to relieve pain and discomfort, using other pain management techniques such as heat or antispasmodics to relieve discomfort, and providing patient education on preventive measures, treatment modalities, and signs and symptoms associated with complications. Patient education is vital to the patient care and long-term reoccurrence and complications related to UTI. The patient should be educated on reporting elevated temperatures, flank pain, nausea, and vomiting, which may indicate the spread of infection and antibiotic resistance or the need for hospitalization. Increasing fluids will prevent dehydration and flush urine of bacteria. Preventing UTI is also necessary in terms of hygiene and educating patients on wiping front to back and urinating before and after intercourse. It is important that patients understand the need to finish their complete course of antibiotics to avoid recurrent UTIs and those that are antibiotic resistant. They may also need education on other medications like pyridium, which is used to treat urinary irritation associated with UTI, as this will cause their urine to be orange and red in color. Early recognition of UTI and prompt treatment are essential to prevent recurrent infection and the possibility of complications such as kidney disease, sepsis, urosepsis, strictures, and obstructions. Complications are usually associated with patients not taking their full course of antibiotics, infections that are antibiotic resistant, or infections going untreated for too long and traveling to the kidneys. So the answer to this one is two. Systemic symptoms such as fever, nausea, vomiting may be present, and more localized flank pain may also be present and indicate the infection has potentially migrated to the kidneys. Upper UTIs are much less common than those in the lower urinary tract. Acute pyelonephritis and chronic pyelonephritis are thought to be the most common type. With interstitial nephritis, this is inflammation of the kidneys, and kidney abscesses, also potential cause. Upper UTIs are common cause of urosepsis. Pyelonephritis is an inflammation of the renal tissue and urinary collecting system. The most common cause is a bacterial infection that occurs as a result of contamination of the urinary meatus. A major risk factor is multiple urinary tract infections. Presentation is consistent with infection and includes fever, chills, and also costovertebral tenderness. Urinalysis shows pyuria, bacteria. Cultures are necessary before starting antibiotics. If pain and fever last for over 48 hours and the patient deteriorates, they may require surgery. It is necessary for nurses to administer antibiotics and monitor vital signs. Recurrent infections or poorly treated pyelonephritis can lead to scarring, chronic kidney disease, or permanent damage to the kidney function. The bacteria can migrate to the bloodstream from the urinary tract, releasing endotoxins that initiate the inflammatory cascade. This releases cytokines and initiates the complement cascade. Widespread inflammation alters metabolism and can cause multi-system organ failure as a result of severe sepsis and septic shock. Changes in mental status, fever, tachycardia, tachypnea, hypotension, oliguria, and leukopenia are the early signs of urosepsis. Renal stones may result from high concentrations of waste that attract other chemicals and grow into stones. A functional urinary system allows for appropriate bladder filling and complete bladder emptying. If voiding dysfunction goes undetected and untreated, the upper urinary system may be compromised. Both neurogenic and non-neurogenic disorders can cause adult voiding dysfunction. Chronic incomplete bladder emptying from poor distressor pressure results in recurrent bladder infection. Incomplete bladder emptying due to bladder outlet obstruction, such as benign prostatic hyperplasia, causes high-pressure distressor contractions, and this can result in hydronephrosis from the high distressor pressure that radiates up the ureters to the renal pelvis. Women are often affected twice as men, and urinary incontinence is more common in older adults. Incontinence is typically a secondary disorder and is associated with another disease process or alteration. Pelvic floor trauma can result from vaginal childbirth and can cause trauma to the pelvic floor, which can then weaken the muscles. Urinary prolapse, also known as bladder prolapse or systole, occurs when the bladder bulges into the vaginal wall. This happens when the pelvic floor muscles that support the bladder weaken, which can then be caused by a number of factors, including pregnancy, childbirth, aging, heavy lifting, chronic coughing, and pelvic surgery. Damaged nerves can send the wrong signals to the bladder or not at all. This can be caused by childbirth, diabetes, multiple sclerosis, or surgery. Being overweight can put pressure on the bladder, weakening the muscles over time. Stress incontinence is the involuntary loss of urine through an intact urethra as a result of exertion, sneezing, coughing, or changing positions. Urge incontinence is the involuntary loss of urine associated with a strong urge to void that cannot be suppressed. Functional incontinence is the involuntary loss of urine due to a patient without overt neurological dysfunction. Iatrogenic incontinence is the involuntary loss of urine due to extrinsic medical factors, predominantly medications. One such example is the use of alpha-adrenergic agents to decrease blood pressure. Mixed incontinence encompasses several types of urinary incontinence, involuntary leakage associated with urgency and also with exertion, effort, sneezing, or coughing. Overflow incontinence occurs when there is continual leakage of urine from an overdistended bladder. This can occur because of distressor muscle weakness. When educating patients with incontinence, you want to include information on behavioral treatments and pharmacological treatments. Lifestyle changes also, which may include drinking enough fluids, avoiding constipation, maintaining a healthy weight, and avoiding smoking, limiting alcohol, caffeine, acidic foods. Kegel exercises help strengthen the muscles that control urine flow. Voiding diary allows clients to track and therefore change their voiding patterns. Biofeedback uses sensors to help the client isolate and strengthen the muscles necessary for voiding. Prompted voiding involves urinating on a schedule, gradually increasing the time between trips to the bathroom. And finally, physical therapy can help with strengthening and retraining the pelvic floor muscles and improving bladder control. Women with stress incontinence may undergo an anterior vaginal repair, retropubic suspension, or needle suspension to reposition the urethra. Procedures to compress the urethra and increase resistance to urine flow include sling procedures and placement of periurethral bulking agents such as artificial collagen. Pessary devices are commonly used with women who have prolapse. An artificial urinary sphincter can be used to close the urethra and promote continence. Men with overflow and stress incontinence may undergo a transurethral resection procedure. This is often referred to as a TURP, and patients may come up to the floor after this procedure with a continuous bladder irrigation. This procedure relieves symptoms of prostatic enlargement, and an artificial sphincter can be used after prosthetic surgery for sphincter incontinence. So the answer to this one is 2, 3, and 4. Stress incontinence involves a small leakage of urine when a patient laughs, coughs, or lifts something heavy, not if a patient just carries on a conversation. Urinary retention is the inability to empty the bladder completely during attempts to void. Chronic urine retention often leads to overflow incontinence. In adults older than 60, 50 to 100 mLs of residual urine may remain after each voiding because of the decreased contractility of the distressor muscle. So this may be normal in that age group. Urinary retention can occur post-operatively in any patient, particularly if the surgery affected the perineal or anal regions and resulted in reflex spasm of the sphincters. General anesthesia reduces bladder muscle innervation and suppresses the urge to void, impeding bladder emptying. Urinary retention may result from diabetes, prostatic enlargement, urethral pathology such as infection, tumor, or calculus, trauma to the pelvic region, pregnancy, or neurological disorders such as stroke, spinal cord injury, multiple sclerosis, or Parkinson's disease. Some medications, including antihistamines, antidepressants, anticholinergics, and antihypertensives, may also cause urinary retention either by inhibiting bladder contractility or by increasing bladder outlet resistance. These are some questions that the provider or nurse may use to help in determining the case of urinary retention. The patient may verbalize an awareness of bladder fullness and a sensation of incomplete bladder emptying. Retention may be related to a urinary tract infection, so hematuria, urgency, frequency, and nocturia may be present also. A series of urodynamic studies may be performed to identify the type of bladder dysfunction and to aid in determining appropriate treatment. Avoiding diary can be used to provide a written record of the amount of urine voided and the frequency of voiding. Post-void residual urine may be assessed by using either straight catheterization or ultrasound bladder scanner and is considered diagnostic of urinary retention. Normally, residual urine amounts should be no more than 50 mLs in the middle-aged adult and less than 50 to 100 mLs in the older adult. Allowing privacy increases comfort with urination. Proper positioning allows urine to flow more freely from the bladder. Assistance allows for safe use of the urinal or ambulation to the commode. Warm water can help stimulate the need to urinate, and caffeine has an antidiuretic property, so you want to avoid that. Neurogenic bladder is a dysfunction that results from a disorder or dysfunction of the nervous system and leads to urinary incontinence. It may be caused by spinal cord injury, spinal tumor, herniated vertebral disc, multiple sclerosis, congenital disorders such as spina bifida, infection, or complications of diabetes. The two types of neurogenic bladder are spastic or reflux and flaccid bladder. Spastic bladder is the more common type and is caused by any spinal cord lesion above the voiding reflux arc. This is the upper motor neuron lesion. The result is a loss of conscious sensation and cerebral motor control. A spastic bladder empties on reflex with minimal or no controlling influence to regulate its activity. Flaccid bladder is caused by a lower motor neuron lesion, commonly resulting from trauma. This form of neurogenic bladder is also increasingly being recognized in patients with diabetes. The bladder continues to fill and becomes greatly distended, and overflow incontinence occurs. The bladder muscle does not contract forcefully at any time because sensory loss may accompany a flaccid bladder. The problems resulting from neurogenic bladder disorders vary considerably from patient to patient and are a major challenge to the healthcare team. Several long-term objectives appropriate for all types of neurogenic bladder include preventing overdistension of the bladder, emptying the bladder regularly and completely, maintaining urine sterility with no stone formation, and maintaining adequate bladder capacity with no reflux. Specific interventions include continuous, intermittent, or self-catheterization, the use of an external condom-type catheter, a diet low in calcium to prevent calculi, and encouragement of mobility and ambulation. A liberal fluid intake is encouraged to reduce the urinary bacterial count, reduce stases, decrease the concentration of calcium in the urine, and minimize precipitation of urinary crystals and subsequent stone formation. A bladder retraining program may be effective in treating a spastic bladder or urine retention. The use of timed or habit voiding schedules may be established. CAUT, which stands for catheter-associated urinary tract infection, is a problem in the hospitals. So these are some suggestions for nurses to follow. First, only use catheters when necessary, and you want to avoid prolonged catheter use. So you want to make sure you follow your hospital procedures on this. Use sterile equipment and proper technique. Keep the catheter's drainage system closed and sterile. Remove catheters as soon as patients no longer need them. Wash hands before and after touching the catheter and before and after manipulating the catheter site. Use a catheter securement device to prevent movement and urethral traction. Use the smallest catheter possible to allow for proper drainage. Suprapubic catheterization allows bladder drainage by inserting a catheter or tube into the bladder above the pubis through an incision or puncture. The catheter or suprapubic drainage tube is then threaded into the bladder and secured with sutures or tape, and the area around the catheter is covered with a sterile dressing. This may be a temporary measure to divert the flow of urine from the urethra when the urethral route is impassable. This may be a result of injuries, strictures, prosthetic obstruction, or also after gynecological or other abdominal surgeries when the bladder dysfunction is likely to occur. A permanent indwelling suprapubic catheter may be needed in the patient who is incontinent following a spinal cord injury. Stones containing uric acid, stirvite, or cystine are very common. Uric acid stones account for 72% of stones in men. These may be seen in patients with gout. 72% of stones diagnosed in women are stirvite stones, which form in persistently alkaline ammonia-rich urine caused by the presence of bacteria. Predisposing factors for stirvite stones include neurogenic bladder, foreign bodies, and recurrent UTIs. Several conditions, as well as certain metabolic risk factors, predispose patients to stone formation. These include anatomic derangements such as polycystic kidney disease, horseshoe kidney, which is a congenital condition that occurs when the kidneys fuse together during fetal development, forming a U shape similar to a horseshoe, chronic strictures, and medullary sponge disease, which is a rare congenital disorder that causes the formation of cysts in the collecting ducts and tubules of the kidneys. Urinary stone formation can occur in patients with inflammatory bowel disease and in those with an ileostomy or bowel resection because these patients absorb more oxalate. Medications known to cause stones in some patients include antacids, vitamin D laxatives, and high doses of aspirin. However, you want to make sure that you understand that in many patients, there may not be a cause found. It is very important for the nurse to assess for signs of advancing infection and severe pain. Renal colic, which results in waves of sharp, intense pain and may suggest that the stone is blocking the urinary tract, is often associated with nausea and vomiting. The priority is to prevent infection, provide analgesics, and strain the urine. The nurse should be documenting input and output and looking for signs of urinary retention. The patient and family need to understand how to prevent future kidney stones from developing through diet modification, appropriate fluid intake, and monitoring for signs if they're prone to kidney stones. During a ureteroscopy, which is used for removing small stones located in the ureter close to the bladder, a ureteroscope is inserted into the ureter to visualize the stone. The stone is then fragmented or captured and removed. So this is a really neat video on extracorporeal shock water lithotripsy, which is used for most symptomatic non-passable upper urinary stones. The electromagnetically generated shock waves are focused over the area of renal calculus. The high energy dry shock waves pass through the skin and fragment the stone.
What is
Percutaneous nephrolithotomy is used to treat larger stones over 2 centimeters and staghorn calculi, which are located in the renal pelvis and branch into the calces. This is where urine collection begins. A percutaneous tract is formed and a nephroscope is inserted through it. Then the stone is extracted or pulverized. So the answer to this one is 2. If a trial passage is prescribed by the doctor, it is priority to strain all urine to confirm the passage of the stone with actual fragments that need to be analyzed for composition. Sodium causes the kidneys to excrete more calcium, which increases the risk of kidney stones. You should limit the salt intake for your patients and also educate on this when they leave and are discharged. The client should also get enough calcium, but not too much. The client could get calcium from milk, cheese, yogurt, or plant-based foods like beans, dried peas, lentils, and nuts. Oxalate is a compound in some foods that can bind with calcium to form kidney stones. The client should limit or avoid foods high in oxalate, such as beets, soy products, spinach, sweet potatoes, rhubarb, and peanuts. Drinking adequate amounts of water helps to flush the kidneys and provides adequate hydration, which decreases the chance of stones forming and also just overall dehydration. The answer to this is 1. This statement indicates the need for further teaching. A low sodium diet can prevent stones by decreasing the risk of dehydration and also the formation of higher calcium. The extent of trauma is dependent on the mechanism, force, and speed of impact. Some common causes include motor vehicle collisions and falls. Urinary output can be reduced or absent as a result of the trauma, depending on the damage to the renal system. Shock may also be present. Common signs include visible blood, decreased or no urinary output, and a distended bladder. The priority is to prevent hemorrhage and shock. The nurse should administer fluids, analgesics. The improving patient's pain will be under control. Absence of bleeding and adequate urine output will also be present. Tumor formation in bladder cancer is attributable to genetic changes in target cells. Smoking is the most important risk factor in the US. Painless hematuria is the most common presenting symptom of bladder cancer. Cystoscopy and examination of the bladder with a scope is the definitive diagnosis. Treatment is achieved through immunotherapy, targeted therapies, and surgery. The nurse must administer medications and monitor for complications. So the answer to this is 4. Cystoscopy with biopsy or examination of the bladder with a scope is used to make a definitive diagnosis. This is coupled with a biopsy of any lesions that are discovered through the examination. Prior to treatment, a biopsy is done to determine the depth of invasion. Intravesicular chemotherapy may be given before surgical treatment, and radiation is indicated postoperatively. The surgical interventions for low-grade bladder cancers consist of removal of the tumor through a fulguration or laser ablation. Fulguration destroys the tumor by using high-frequency electrical currents, and laser ablation destroys tissue by eradicating it with a laser beam. Another approach for surgical management of invasive bladder cancers is a cystectomy. This is also combined with chemotherapy, and it offers the best chance of cure or extension of disease-free state for the patient. In male patients, the procedure involves removal of the bladder, prostate, seminal vesicles, lower ureters, and in some cases, the urethra. In female patients, they remove the bladder, uterus, ovaries, fallopian tubes, anterior wall of the vagina, lower ureters, and often the urethra. These procedures may also involve pelvic lymph node dissection in both male and female patients. And these procedures may also involve urinary diversions. So here's a video of the procedure. You want to watch that on your own. So you want to monitor output to assess kidney function. Make sure the stoma is beefy red and patent. Monitor urine output color and characteristics to check for complications. Encourage fluid intake to flush irritants. Provide analgesics as needed. And provide education to assist the patient and their family with adjustment and management of the urostomy. Here's a knowledge check. The answer is 3. This statement indicates teaching effectiveness because smoking is the most important risk factor for bladder cancer in the United States. A urinary diversion is a surgical procedure that reroutes urine flow to allow it to exit the body as a result of bladder cancer. So the types include the ileal conduit, which diverts urine from the upper urinary tract to a newly formed reservoir created from the terminal ileum. Orthotopic neobladder reconstruction is a reservoir made from the small intestine that allows urine to be passed through the urethra. Continent urinary diversion is a pouch made from the large intestine with an outlet made from the small intestine. And here's a video of the urinary diversion ileal conduit. Watch that on your own. Cardiopulmonary function assessments are performed because patients undergoing cystectomy are often older adults who may be at greatest risk for cardiac and respiratory complications. A nutritional status assessment is important because of possible poor nutritional intake related to underlying health problems. And learning needs are assessed in consultation with the nurse and possibly the dietitian. And if your hospital has a urostomy or ostomy nurse, they may help as well. The role of the nurse in the immediate post-operative period is to prevent complications and to assess the patient carefully for any signs and symptoms of complications. The catheters and any drainage devices are monitored closely. Urine volume, patency of the drainage systems, and color of drainage are assessed. A sudden decrease in urine volume or increase in drainage is reported promptly to the provider because these may indicate obstruction of the urinary tract, inadequate blood volume, or bleeding. A supportive approach, both physical and psychosocial, is needed and includes assessing the patient's self-concept and manner of coping. A low residue diet is prescribed to cleanse the bowel to minimize fecal stasis, decompress the bowel, and minimize post-operative ileus. explanations of the surgical procedure, and the appearance of the stoma, the rationale for preoperative bowel preparation is also explained. Complications may include respiratory disorders, including atelectasis and pneumonia, fluid and electrolyte imbalance, breakdown of any sepsis, fistula formation, fecal or urine leakage, and skin irritation. Education allows the patient and their family to achieve the highest level of independence and care possible. So the answer to this one is 4. This statement indicates that teaching was effective because the patient will wear a drainage bag or pouch to collect the urine. So this is a video. It's a little long, so you can watch it on your own. It goes through changing the urostomy and gives a really good educational step-by-step. So we're at the end. I just want to encourage you, if you have any questions or concerns, to reach out to me directly or through email. Thank you.